Welcome everyone to today's webinar. My name is Michelle Nichols, and it is my pleasure on behalf of the Public Health Alliance for Genomic Epidemiology to welcome you to today's webinar. I will be moderating this session, and as a reminder to please stay on mute while the speaker is presenting. You have the ability to type in any questions in the Q&A forum, and at the end of our presenters' talk today, I will read those questions out to you. We will also have the ability to have your questions answered. Should we run out of time and not be able to get through them all, you will be able to follow up and get responses via email. Today we have our talk is entitled Ethical, Legal, and Social Considerations for Real-World Data in Public and Private Domains. It's my pleasure to introduce Dr. Rachele Hendricks-Sturrup, who is the Research Director of Real-World Evidence at the Duke-Margolis Center for Health Policy. Prior to this role, she served as Health Policy Counsel and lead of the Future of Privacy Forum and Research Fellow at Harvard Pilgrim Healthcare Institute. As a researcher, bioethicist, and policy practitioner, her work centers on addressing implementation and ethical, legal, and social implication issues at the intersection of health policy and innovation. Dr. Rachele Hendricks-Sturrup, it's my pleasure to turn it over to you now.
Thank you so much for the very warm introduction. I will go ahead and start sharing my screen and slides for our presentation today. So thank you all for joining. It's certainly my pleasure to be here and speak with you all about this very important topic, a very 21st century topic that we have in front of us. So as Michelle mentioned, the talk of my presentation is entitled Ethical, Legal, and Social Considerations for Real-World Data in Public and Private Domains. I'm the Research Director of Real-World Evidence at the Duke-Margolis Center for Health Policy in Washington, D.C. So for those of you joining from parts outside of the U.S., you're welcome to the presentation and welcome from Washington, D.C. So I'll get started by just going over some very broad definitions of real-world data, particularly as regulators across the health industry have defined it. So here at Duke-Margolis, a lot of the work that we do, or at least within the real-world data space, a lot of the work that we do centers on informing the Food and Drug Administration here in the U.S. To guide them in their decision-making and consideration of real-world data. And in doing so, we consider the definition of real-world data as you see it here and as it's defined by the FDA, which is data relating to patient health status or the delivery of healthcare, and data that's essentially collected from a variety of sources. This would include electronic health records, which exists within a private domain, claims and billing activities, which are private as well, in addition to product and disease registries. Now, what's not so private, or probably a little more out of the health regulatory space, is patient-generated data, data that is generated through personal devices, generated at home or in other public spaces, usually through a smartphone or some sort of mobile device like a smartwatch as well. So really running the whole gamut of data from all of these sources as they can become or are health relevant. And then the European Medicines Agency, or the EMA as it's called, they've provided their own definition of real-world data as well, be it just like the FDA's definition, data from electronic health records, insurance claims data and patient registry data, specifically calling out genomics data, clinical trials data, which is a bit distinct from definitions the definition of real world data by the FDA, which effectively does not consider clinical trial data. And then also adverse drug reaction reports, social media data, and also wearable devices. So just between these two definitions, we see some similarities as well as some differences that are certainly of consideration from a policy standpoint when determining how to best protect or handle or manage this real world data. And then the Association of the British Pharmaceutical Industry has an even broader definition, which is patient data that are routinely collected outside clinical trial situations. So already here we see a third variant in terms of how real world data is defined across the global landscape, or at least the portion of the global landscape that I've presented here. So patient consumer spectrum data. This is a term that I came to adopt in my work because I thought it was an all-encompassing term that really captures the nuance as well as the context in which data that is health relevant, that is, flows across what I like to consider being the patient consumer spectrum. So what is that? What is the definition of that? It's what you see here on this slide. It's a growing concept in which healthcare is rapidly transitioning from a periodic activity in fixed healthcare settings to rather instead an around-the-clock activity that involves the generation, use, and integration of data that reflects information about not just a person's health, but also their livelihoods, their health behaviors, their health choices, and other things. And this illustration here is something that I helped develop during my time at the Future of Privacy Forum. The illustration essentially shows how health data really flows along this spectrum. The spectrum being what we've color-coded here, HIPAA-covered, data from HIPAA-covered entities and also data from non-HIPAA-covered entities. So for example, the hospital that's colored in purple, that's a HIPAA-covered entity here in the United States. HIPAA-covered essentially means that the data coming from this entity is, coming from these types of entities are data that being housed or sourced from health insurers, healthcare providers, and their business associates, as it's defined by the HIPAA law. And then also what's perhaps less clear or data coming from non-HIPAA covered entities are other emerging types of healthcare models. For example, the Genomics to Go clinic that you see here in this illustration. That's actually, this particular graphic was inspired by a recent development in Boston, Massachusetts at Harvard Medical School, where physicians came up with an idea to provide on-the-spot direct-to-consumer genetic testing right there inside of the health clinic. So for those of you who are interested in learning more about that work, I can point you in the right direction. But this illustration essentially captures what we're seeing today, including nurse bots here, what you see on the laptop, health apps, ride-sharing apps that can take people to and from healthcare facilities. All of these entities collect data, and the data is sometimes protected under traditional healthcare laws and sometimes they're not, but they all are very health relevant. But because only some of these data sources come from traditional healthcare entities, they also, there are certain legal considerations for that data in terms of its protection, privacy protection, that is. So what are the implications for real world data across this spectrum? Well, this disambiguation that I provide here just essentially provides an overview of some of the legal and regulatory considerations that are in front of us. So in the top circle, you see traditional healthcare data, be it registry data, clinical labs data, electronic health records, and then in the lower corner, you have genomic data, inclusive of direct-to-consumer data, and then also on the other end, wearable device data or health app data, for example, that fall under the bracket of largely unregulated data, that is genomic data, direct-to-consumer genomic data, and wearable device data. when alone or combined, they're largely unregulated, particularly by traditional healthcare laws that were put in place to protect the privacy and also safeguard the management of that data on the day-to-day. And the combined uses of all of these data, where they overlap, where these arrows point to, that is, there are unprecedented legal, regulatory, ethical, and social or societal challenges because all of these data sources, alone or combined, are accompanied by sensitivities that are largely unaddressed and mostly navigated on a case-by-case basis with little guidance from broad industry or guidance from policymakers. I want to talk a little bit about open data. I know many of you here are interested in or specialize in genomics and health data. So I want to talk a little bit about along the patient-consumer spectrum, what open data looks like from a genomic standpoint. So open genome data today is available online. And some of you may even be aware of this through Open Humans, for example, the Personal Genome Project. These data sources provide identifiable patient-consumer spectrum data that's available to the public, inclusive of being available to genomic health researchers. Now, some of the broad societal implications, at least as it concerns privacy, that really flag at least my concerns and concerns among others who are interested in this topic. This flags concerns particularly because as the data remains open and available to the public, that means that anyone can get a handle on it to understand some of the health risks that accompany each individual or data subject within these databases. And as algorithms are deployed across various websites by various companies or industries or entities that are looking to understand or at least risk adjust for some of these individuals or populations that these individuals belong to, the data is openly available for them to be able to do that. So some glaring issues that I flagged here are just a few examples where life, long-term, and short-term disability insurers, long-term care insurance underwriters, they have access to this data. And currently, the laws that are in place now, at least here in the US and in other places like Australia, in Canada, there's wide variation in terms of what these particular insurance companies are able to underwrite for based on genetic data, especially direct-to-consumer genetic data. And while here in the US, we do have the Genetic Information Non-Discrimination Act, life, long-term care insurers and also long and short-term disability insurers are excluded from this law. So they have, there are opportunities for these particular entities to make use of this data to inform their underwriting procedures. And then also home mortgage lenders, those offering 30-year or more mortgage services, they also have access to this data. So should someone looking to buy a home that might be of a certain adult age, based on their genomic health data, it could be inferred that this person might not live for 30 years in order to be able to pay their mortgage for the duration of that 30-year contract. So this is one example, another example rather, of this data being available to entities like home mortgage lenders. Also military personnel, they have actually been warned by military entities, particularly the one here in the US. They've been warned or at least cautioned to not engage in direct-to-consumer genetic testing because military officials are able to use that data to determine a person or soldier's readiness to serve. And should the data reveal something, or, for example, a genetic risk for a familial disease, that information could be used against the person seeking to enlist in the military. And then also there are other implications here, implications for known and unknown biological family members who might not know or understand genetic risks that they might carry for disease. Political exploitation is always a risk, including employment discrimination. Whereas at least here in the United States, employees bear the burden of proving that they were discriminated against by their employer based on their genetic information. So even though there are protections like the Genetic Information Non-Discrimination Act that prevent, or at least that serve to prevent employers from discriminating against employees based on their genetic information, the employee is the one who bears the burden of actually proving that they were discriminated against. So there are court proceedings, or at least nuance within court proceedings that must even be considered there. So I want to share some of my research and progress with you all. This work was recently completed by me and my colleague at Harvard Pilgrim Healthcare Institute, where I've conducted research at in the past. This work is, as I mentioned, in progress and under potential publication. And so this was actually a survey that I conducted among individuals registered in a database called Research Match. It's a database here within the United States where individuals who are patients can sign up to first register to participate in the database, and then second, be contacted through their engagement in the database, be contacted by researchers to engage in various studies that they might be interested in. So this particular study that I conducted, as I mentioned, was in Research Match. And the purpose of this study was to examine how demographic factors might shape or influence study participants' perspectives about the health relatedness of various types of their consumer generated data, inclusive of their direct-to-consumer genetic test data, and also assess their privacy concerns about all of this. So some of the demographic factors that I looked at are age, education level, duration of using online medical websites, as well as annual frequency of getting ill. And also, just a few details about Research Match. At the time of the study, which I conducted in April of last year, 2021, there were almost 150,000 registrants in the database. And the registrants actually live within the United States, including Puerto Rico, and are of all ages, races, and ethnicities, and consist primarily of healthy individuals, as well as those living with medical conditions. So the survey was distributed to 598 registrants who agreed to be contacted after receiving some information about the study. The study was IRB approved by my institution at the time. And out of these individuals who received the invitation, 402 actually completed and submitted the survey. So that gave me a really good response rate. About 86% of those who received the invitation completed the survey, which is great. And the participant demographics that I saw are what I described here. Just about all of the participants were over age 21. I did have a few that were between the ages of 18 to 21, but very, very few. Most of the participants, around 87%, had either some college, associate's degree, or trade school, a bachelor's degree, or a master's degree. And 56% of the participants reported to have used online medical websites for 7 years or more. And also, or lastly, here, what you see in the last bullet, most of the participants, or 94%, reported an annual frequency of getting ill of 6 occurrences or less. So here's just a very high level overview of what this population looked like, at least the population that participated in this survey. So I want to provide some preliminary results, based on, what the respondents said to me in response to my survey questions. So one of the questions they were asked was to rate on a scale of 0 to 10, with 0 being the least, 10 being the most, the health relatedness of various sources of digital and electronic data sources. And so what you see here in this graph is, probably not surprising. Electronic health records, which are at the very bottom, had the highest health relatedness score. And that's followed by wearable fitness trackers that had the second highest rated health relatedness score. And then in third place, or the third runner-up, is commercial genetic profile data. So largely respondents felt that these three data sources were the most health-related out of all of the data sources covered here. And you'll see that here on the y-axis, frequent flyer accounts, electronic toll payment device data, home monitoring cameras, online reviews, social media, internet browsing history, really, the whole gamut here. Grocery store rewards cards, all of these things that probably could be health related or have some health relevance, but according to this group, they did not feel that they were very health related, at least not in comparison to commercial genetic profile data, wearable fitness tracker data, and electronic health record data. Now, looking at this with a finer lens, based on the participants' age ranges, the age ranges are what you see here coded in color at the bottom of the graph. Really, the groups, there was really no observable difference among each age range group in the health relatedness of each data source. So I saw this, this pattern here for each age group, very, or at least seemingly homogeneous in terms of, the health relatedness scores provided across each age group. Now, however, when I looked at the data by education level, or at least stratified by education level, I did see quite observable variation here, particularly among high school, or at least respondents with high school education, which comprise about 3% of the total survey respondents. So I did see that this particular group, those with a high school education, they tended to rate these data sources a bit higher relative to the other groups with higher levels of education. So I found that to be quite interesting, and this is actually an observation that I'm digging into a bit more to understand whether or not there's any significant differences of note here. But it is something that is easily observed here in this graph, and definitely something to think about for my discussion. So looking at the same data, or at least looking at the same population, stratifying for their duration of using online medical websites, and the number of years that is, the color codes are seen at the bottom. I started to see some wider variation across each group here, but largely, they overlap. It appears to be quite homogeneous. However, we are in the process of measuring whether or not there are some significant differences of note here as well. Most interestingly, those who were, not quite sure about how long they've been using online medical websites, they tended to, that's the dark purple line that you see at the bottom of the actual graph. This group seems to have scored a little bit lower than the others, but not really sure yet whether or not this is a significant difference. Our preliminary analysis suggests that there's not, but we're digging more into this, and it's something to think about as well. Once we stratified for the annual frequency of getting ill, that is, the number of times per year, that is how often, in terms of how often they get ill, there's, homogeneous observations among the group here. Nothing really of note, but again, we are in the process of determining the levels of significance and what we observe here in these graphs. Now, when I asked the participants about their privacy concerns and free text, I took that free text data and created word clouds that you see here. And so I separated each group based on whether or not the comment they provided held positive or negative sentiment. So those with positive sentiment felt that when asked about was or not they'd be interested in donating their electronic data to researchers today or in the future, those with positive sentiment, which was about 38% of respondents, a lot of them provided or at least shared words that you see here in red and also in black bold. They seem to have felt that there's benefit in sharing their data, benefit to the sake of, donating their data to research, to inform healthcare decision-making. There's benefits, or at least benevolence, in donating their data because they trust the researchers to use it in a good way. They want to contribute to the education of others, and they also want to know more about their own medical conditions as well. So essentially, the words that you see here indicate, or at least I believe truly indicate, a positive sentiment around data sharing among this group. However, those who express negative sentiment, which was actually a larger portion of this group, 62% expressed negative sentiment, where they had what you see here: concerns about privacy, concerns about how their health data would be used, who would be accessing it, how it would be secured, how it would be kept confidential. They worry about the data getting into the wrong hands. They worry about data breaches, particularly if data security measures are low in some places. And they also have concerns about insurance companies getting a hold of their information. So what I observed here is that the research match population is very concerned, or at least most of the research population is very concerned about their data getting into the wrong hands or being misused in any sort of way that would encroach on their day-to-day needs and living. And I think there's opportunity to address these concerns in the future, and definitely something to think about when determining other hypotheses that we could generate to examine privacy concerns in this population, as well as examine interventions that could be implemented to address these concerns. So I'm going to stop right here to engage everyone in a poll activity. I want you all, if you're able, to join me at slido.com at the number you see here, 587-315. The link to the Slido poll is also provided in the chat to you all. The Slido poll activity asks you all, should the privacy of consumer-generated health data be, should the privacy of this data be treated the same as traditional healthcare data? So thinking back about the, in the slide that I provided about the patient-consumer spectrum and how some of that data is treated or protected rather as traditional health data under laws like HIPAA. Should consumer-generated health data be treated the same or protected similarly given its sensitivity? And also given, some of the insights that I shared with you all today about what Research Match participants think. I'm curious to see what you all think about this. So please take a moment to participate in this poll. I do have the results live in front of me, so I'm able to share the results with you all at the end. So I'll give it a minute or so to give everyone a chance to participate. So far, it looks like I've got 5 or 7 votes. So thank you all. To those who have participated already, thank you so much. And I encourage everyone else who hasn't to do so. This is a topic that continues to be under debate here in the United States. In fact, we had recent legislation become introduced by a bipartisan bill actually become introduced here in the United States as one attempt of many to protect the sensitivity of patient consumer spectrum data. And we have other laws, comprehensive privacy laws at the state level here in the US that have attempted to do so already. We've had California pass a law, as well as Colorado and Virginia. Fortunately, here in Virginia where I live, at least I know my patient consumer spectrum data could be protected to some degree. All right, so we've got 11 votes so far. I can share that most of you feel that yes, the privacy of consumer-generated health data should be treated the same as traditional healthcare data. 18% of you said no, while 82% of you said yes. So thank you for participating in that poll. I hope you all enjoyed it. That being said, I'll go ahead and move on to the next slide. I can share with you all some results from this very same poll that I conducted a couple of years ago. at another conference with a colleague of mine, Dr. Sarah Jordan, who was also at the time my colleague at the Future of Privacy Forum. Just over half of the audience members who participated in the poll felt that consumer-generated health data should be treated the same as traditional health data. So I see a difference here in this group where 83% of you, now that we have 12 votes, 83% of you say that yes, it should be protected. So it's interesting to see how your perspectives differ from the perspectives of this group just a couple of years ago. And so I do want to note that as many of us were kind of forced online, or at least into digital settings due to COVID, I would imagine that, COVID might have had an influence on how some of us perceive the privacy of our digital data, now that many of us have been forced to engage in a digital way because of the COVID-19 precautions and closures and shutdowns and so forth. So just something to think about of interest. And here are my key takeaways from this presentation, which are first and foremost, there might be a need for digital health literacy training or education development among research matched participants, those particularly who have an education level at or below high school. Thinking back to the finding that I showed you all, where this particular group tended to, or at least based on the graph that we observed, they tended to rate the health relatedness of digital data sources a little bit higher than others. So there might be a need for some training among this group, as we move more and more into the digital age. And as more patients and consumers increasingly engage in or manage their health through digital means, again, a phenomenon accelerated by the COVID-19 pandemic, stronger or more comprehensive privacy protections are needed, especially for patient consumer spectrum data. So thinking into the future where, knock on wood, we may experience, other COVID-related shutdowns, hopefully not, or other pandemics where other public health emergency situations like today's pandemic might happen again. We need to make sure that patient consumer spectrum data can't be exploited. So we really need to focus on the privacy, or at least measures we can take today to protect the privacy of that data tomorrow. And also we need to leverage or create opportunities to address digital health research participants' privacy concerns. As you saw in one of my slides, there are lots of unresolved privacy concerns, lots of risks that are out there regarding how this data can be used in real world settings. So we really need to do more, or at least find or create more opportunities to protect this data, especially in the absence, at least here in the United States, in the absence of a federal comprehensive privacy law. Even if we do have laws that exist at the state level, there are only a handful of states that have comprehensive privacy laws, and there's variation even there across each of those state laws. And then also there's still a gaping hole or lack of protection for other populations within the United States and other countries. So opportunities to do this should not be missed. Here's a list of my research that has been published to date on this topic. My most recent paper that was published just a few weeks ago is actually in JMIR Health Health, where I conducted the first, if not the only, assessment of pulse oximeter app privacy policies during COVID-19. One of the key findings there are what you just saw on my last slide, is that there's a big need to protect the privacy of individuals' consumer health information, especially as they engage in apps that are health related, to make up for the lack of over-the-counter medical devices or products like pulse oximeters, that go in short supply due to public health emergencies. So as over-the-counter products go in short supply, and as individuals are forced to engage in the digital space or realm to manage their health, we need to make sure that that data is protected. So I encourage you all to take a look at my work there and other publications that you see here. If you have any questions for me or would like to get in contact with me, here's my email address. As I mentioned before, I'm the Research Director of Real World Evidence at the Duke-Margolis Center for Health Policy. My email is rachel.hendricks.sturrup@duke.edu. It was a pleasure presenting to you all today. It was a pleasure to share some of my work in progress. I would love your feedback. I would love to answer your questions if you have any. And I'll go ahead and stop there.
Great. Thank you so much, Rachel. I really appreciate it. I found your talk to be very exciting and engaging. It aligns with some of the areas of my own work. I have my own apps I've developed to collect data, use activity trackers, ecological momentary assessment. And it's been surprising how some of my population has not been concerned at all with privacy. And yet, as a clinician, scientist, and bioethicist myself, I am very much concerned about this. Yet they don't seem to have those concerns even when asked directly. So thank you for the engaging conversation. We do have some questions. The first question we have is the message that genomics and other data, i.e. IoT devices, et cetera, need to be regulated? If health relatedness is perceived high for these types of data, what does that mean with regard to what should be regulated versus not?
First off, that's an excellent question. And I think that's precisely what legislators are trying to understand. For one, how does the public perceive the health relatedness of this data? How are companies treating this data in terms of its health relatedness or not? And I think from there, coming up with a sort of risk stratification process to, sort of meet the data where it is versus for what it is at the time. I think that's the approach that a lot of policymakers are trying to take, or at least are encouraging themselves and others to take. It's a right now, as we engage various stakeholders in this topic, it's something that continues to be debated. There is really no consensus around how we should start with regulating this data based on, for example, as I mentioned, what the data is called. Simply because it's called a health app, does that mean that we need to treat it, more or less sensitive to other types of data, like grocery store rewards data, for example, where, again, the details, or at least the level of detail around how that data can be used or perceived as health related, it's subjective. There are some who might say, absolutely, my grocery store rewards data is health related because I take my health seriously through my diet. There are some who might have perceived the health relatedness of their GPS or location data as very health related because they go to the doctor a lot and they go to specialists often and they track that information through their GPS data records. So again, it's a very subjective topic. And I think policymakers are also trying to figure out how to approach this. And I think the question that this person raises is a good one. Where do we start? How do we start somewhere? It could be that more surveys like this one are needed in order to understand how the public perceives one data type as health related versus another, and then at least try to come up with some sort of consensus building around how policymakers can create laws that would protect that data, at least today or in the near future.
Great, thank you. Another question we have is, how could one avoid personal bias when studying or discussing patient/personal data privacy? For example, an academic researcher might be more inclined to be a proponent of stricter privacy policies, while an industry researcher might advocate for policies that might be deemed a little lax to enable commercial exploitation of the data.
Again, that's something that continues to be debated. And, one of the things I like about what I do is that, in my role where I engage lots of stakeholders, including industry, including academics, including patients, trying to work honorably on all sides and trying to meet the interests of all sides where they are to come up with something that everyone can agree on. That it's a very, very tough challenge. No one has really figured out how to, make everyone 100% happy. I have heard comments from others in industry who have said, well, you know, the laws like the GDPR in Europe, General Data Protection Regulation, that would be disastrous for the US data economy. I've heard comments like that. I've counteracted those comments by saying that, well, you know, while myself, you know, as someone who works on all sides, I would probably disagree with that statement, because I think it's more about responsible use of data, not necessarily not using the data, is where we need to go to, you know, find a happy medium for everyone. I think that is really how we should look at it. And I've even heard patients themselves, especially rare disease patients, say that they want to share their data, because by not sharing it effectively, it's a disservice to them as they work with researchers and even industry as well on coming up, or at least finding successful therapies to treat their rare diseases. So really, I don't think there's one draconian way of doing this. I think what's more important is about getting all of the right stakeholders to the table to try to meet everyone where they are in their data journeys and figure out the best way to move forward.
Great, thank you. We have some comments about a great presentation. And they're thanking you for your talk. We also have another question here. How can we balance between data sharing and privacy, especially nowadays? This would impact the health of others. For example, COVID-19 pandemic situation.
Absolutely. Well, you know, as I, you know, just mentioned in my last comment, you know, I think it's all about getting the right stakeholders to the table. I think it's easy to, as another, you know, comments were mentioned, it's easy to indulge in our own biases around, you know, what should be shared or what should not be shared and who should use data and how. But I think coming to the table with an open mind, and this is everyone, inclusive of industry and academics and others and patients as well, coming to the table with an open mind to say, look, this is the world we live in now. Data is collected everywhere. We're generating data every which way we go, and way and how. What can we do today to make sure that we are able to steward this data in a way that's meaningful for society, meaningful for families, meaningful for institutions that are looking to educate others on how to meaningfully share this data or steward the data? How do we make sure that industry can stay afloat, because they create jobs and they create opportunities for people who leave academia often. But how do we even educate them to do things responsibly? I think it really boils down to the ethics around what everyone's trying to accomplish. And then also looking out for, you know, those who might want to exploit that data. What are some safety protocols that we can have in place to make sure that individuals can't do that, whether intentionally or even unintentionally. Sometimes it's the case that they don't know that they're exploiting this data and they have to be told down the line. So again, bringing the right stakeholders to the table to figure it out together at the right time and in the right moment is usually the best way moving forward at this point, in the absence of any comprehensive privacy law or successful legislation.
Great, thank you. I like that terminology of stewarding the data. I think that's a really good take on that. We do have another comment here and question, thanking you for the very interesting work and asking if they can take a look at the reference list slide again. So if you can easily pull that up, that would be great.
I certainly can. One moment while I do that.
Great. And while you're doing that, let me just see if there are any additional questions that have come in.
All right. And I just want to confirm everyone can see the slide now.
I can see the slide. I don't know if everyone can, but it.
Great.
And now we have another question that has just come in, if you don't mind taking another moment here. Do you think commercialization of data could be justified on the ground of some compensation earlier given?
You know, when I hear this this question come up, I think about, for one, who is being compensated and where and how, and then usually the answer is, well, the data subject, should they be compensated for sharing their data? And also another, to that point, I've heard and have read work, research and policy work on the topic of data as property, and what are considerations there? How do we compare data as property compared to, for example, someone's home as property, or land as property? Should it be treated the same? Should it not be? And then also along that same vein, there are members from industry who say, well, data is not data until we make it data. And it's our platforms and our tools that make, one's behavior or choices, online browsing choices or behaviors, for example, the data that it is. So, essentially the data subject, while they're the data generator, we're the data, we're the data holder. We're the one who actually makes the data what it is, as I mentioned. As far as compensation goes, I think that, for one, I think there's value in sharing data that might be outside of just receiving compensation. As I mentioned before, there are some individuals, stakeholders, who want to share their data, not to receive money or anything monetary, but rather in order to receive a long-term benefit, like a new therapy for themselves and others like them, or their families who carry a genetic disorder or illness. So I think, before jumping to conclusions that people want money for sharing their data, I think we have to talk with the community or multiple communities to first understand what elements of value they're seeking in the exchange of their data, because sometimes it's money, sometimes it's not. And I think that should be handled through, as I mentioned, stakeholder engagement in order to meet people where they are versus assuming what they want.
Great, thank you so much. They did confirm that they can see the slides, so thank you for putting up your reference list again. And at this time, there are no further questions. So I would just like to personally thank you for your really wonderful talk today, and thank all of the participants for joining in.
Wonderful, thank you so much. It's a pleasure to be here and engage with this audience. So thank you for inviting me, and thank you to those of you who have joined today.
Great.